Thank you very much. So I'm going to continue on with the concept of ACL rehabilitation and talk a little bit about how I treat ACL reconstruction in our athletes. And my objectives to start out today is to go over some of the biomechanical and neuromuscular factors that contribute to ACL injury, and then ultimately should transition into how we rehabilitate our athletes. We want to talk about some of the unique factors to consider in rehab, but then also kind of talk briefly about the kind of transitioning from our current program into our return to sport program. And if I had to summarize in one word how I visualize and how I conceptually design my ACL rehab protocol, I would definitely say that I take it from a more mechanistic perspective. And the reason I say that is because I think that the more we understand the mechanism and the better we can appreciate how ACL injuries occur, we can design more efficacious interventions to try to address them. So we'll talk briefly about the mechanisms of ACL injury first, and then we'll discuss how we can implement some of our rehabilitation programs to counteract some of these mechanisms along the way. So when we talk about mechanisms of ACL injury, we know that 72 to 80% of ACL injuries are non-contact ACL injuries. We also know from the work by Markov and Bainin that the greatest load on the ACL is from a combination of forces. It's not just from an anterior shear force, but rather it comes from a triplanar motion, likely anterior shear, internal rotation, and varus and valgus moments. So again, when we think about the injury mechanism, it's not only in one plane that the injury occurs. And as a result, when we think about transitioning to some of our rehab interventions, we need to make sure that we're implementing them in 3 planes. The at-risk positions we know are landing from a jump and sidestep and cutting maneuvers, and this has been demonstrated by authors over the last 20 years. Lloyd, in 2001, published a study in JOSPT. And in this study, he talked specifically about biomechanical and neuromuscular risk factors. And specifically, he examined the kinematics and kinetics during athletic activities such as running, sidestep cutting, and crossover cutting. What he found was that there was increased internal rotation and varus and valgus moments with sidestep cutting maneuvers. And he also noted that these forces were increased with unanticipated maneuvers. So again, we see that it's not merely a factor of activities which are pre-planned, but when unanticipated maneuvers occur, we see that there's an increased force on the knee and improvement as well. But we know when we talk about proprioception, it's not only a component of what we take in from the environment, from our mechanoreceptors, from our visual and vestibular input, but also the response that we get, whether it be on a reflexive, brainstem, or cerebellar level. Now, when we look at assessing proprioception, the literature has identified several different means to assess proprioception in athletes. One being active and passive repositioning techniques, a second being threshold to detection of passive motion, a third being muscle activation or latency of muscle reflexes, and finally being postural stability or postural balance. Regardless of the type of mechanism utilized to assess proprioception in these athletes, the literature has been clear over the last 25 years that after an ACL injury, proprioceptive deficits occur. Concurrently, we've also seen in the literature that after ACL reconstruction, we see an improvement in proprioception. However, it's been the course and the length of time it takes to regain this natural proprioceptive input is somewhat controversial. And we see studies by Coe, Harrison, and McDonald suggesting that a reconstructed knee may have equal proprioceptive abilities to a control group. However, all of these studies were executed between 9 and 12 months after surgery. Barrett noted that reconstructed knees improved after ACL deficiency, as we assume. And finally, McDonald and Fremery noted that reconstructed knees do have proprioceptive deficits versus their non-involved legs. However, this too can resolve over time. So we see some consensus in the literature that after ACL injury, we see deficits in proprioception, and then following ACL reconstruction, we see a slow return. In a study that we published in 2002, we utilized postural balance and postural stability as an assessment tool to determine proprioceptive deficits after ACL reconstruction. And what we noted that the postural stability was significantly affected by ACL injury, and that the deficits lasted between 9 and 12 months after ACL reconstruction. And again, if we think about the time frame that we utilize to return our athletes to sports, certainly we return them before 9 to 12 months after ACL reconstruction. In addition, our data suggested that the contralateral limb was actually a poor control in the assessment of postural stability. Specifically, we noted that there was deficits bilaterally after a unilateral injury. We took our study a step further and looked at gender differences in postural stability. And what we noted that when we looked at our control population, females tended to have superior postural balance over males. However, what we noted was that after ACL reconstruction, the female athletes tended to be more affected. Their postural stability was significantly worse than their males and actually took longer to return postoperatively than their male counterparts. So again, we see differences between genders. So how do we address these in rehabilitation? Now that we have a better understanding of the mechanism of ACL injury, and we know that certain positions and certain motor patterns may predispose our athletes to ACL injury, how do we address this postoperatively? Once they have their reconstruction, how do we address this mechanism specifically? And I'll go back to the same template I used yesterday when I talked about ACL prevention. We should look at these neuromuscular imbalances which exist not only in the males but also in female athletes, specifically being ligament dominance, quadricep dominance, and dominant leg dominance. And we'll use these neuromuscular imbalances as a framework to guide us through the initial stages of rehabilitation. So again, to review from yesterday, ligament dominance is defined as a lack of dynamic muscular control in the medial lateral direction, resulting in increased valgus stress on the ligaments. So from a rehabilitative standpoint, our mission should be to try to attain balance, to try to dampen the effects of this ligament dominance so we can decrease the effects on our athlete who is returning to sport. And if we try to address this, some of the means that we can utilize is to control knee valgus during all our activities and interventions, try to train muscle coactivation, to control knee extension, and to train both hip and trunk musculature to enhance knee stability. So when we talk about controlling knee valgus, this is something that we can do very early on in rehabilitation. And similar to videos from some of my prior speakers, we see that with a step-down task, it's important that we educate and we give our patients cues to ensure that they maintain a hip-knee over-toe alignment and that we don't let their knee move into a valgus knee position. If in the early stages of rehabilitation, with tasks such as a step-down task, we allow our patients to go into a motor pattern such as in valgus knee position, they'll surely continue to mimic this when they go to higher level activities. So again, our goal in this perspective should be to control knee valgus. Again, we can go back to the work by Lloyd in 2001 when we talk about the importance of training muscle coactivation. Lloyd noted that enhanced hamstring and quad coactivation can be an activation pattern that people use to lower ligamentous load. Specifically, what we note is that when we get quadriceps and hamstring coactivation, we get a compression in the joint. And with that compression, we actually can reduce the varus and valgus support of the knee by 80%. So even though we talk about frontal plane motion, our sagittal plane muscles, when they work synergistically, can result in compression and ultimately stabilization in a frontal plane. And to do that, we can train on many different levels. We can utilize an unstable surface, such as we see here, utilize a squatting task in encouraging them to have good form to recruit both their quadriceps and hamstring musculature. And again, giving them a perturbation or trying to distract them in some way. So ultimately, as we progress through the phases of rehab, we can challenge them more and more. Well, what about controlling knee extension? Because full knee extension, as we know, is a vulnerable position for our athletes. And this has been demonstrated by Lloyd, Wilk, and others. So ways that we can improve upon this is trying to train hip and trunk musculature. And we train them through very low-level activities, such as closed kinetic chain strengthening, free weight and body strengthening, which encourages them to recruit their hip musculature and their core musculature, balance and proprioceptive activities, and then higher level activities such as we see here, such as a single leg deadlift on an unstable surface. Well, what about the imbalance of quad dominance? And as we reviewed from yesterday, quad dominance is defined as the preferential activation of knee extensors over knee flexors in athletic maneuvers. Now, and if we are trying to attain balance related to our quadricep dominance imbalance, we want to try to normalize the hamstring to quadricep ratio and enhance muscular endurance and muscular recruitment as well. Some of the means we can utilize to do this, again, can be very low-level exercises, such as hip extension exercises with TheraBand, leg curls, or things such as stool or cart pulls as well. If we want to advance to more higher-level activities, utilizing leg presses with, again, good technique and good form, encouraging wall sitting with slight trunk flexion to recruit the posterior musculature, doing Swiss ball hamstring curls, or something much higher level, such as an assisted Russian hamstring curl, which is what we see demonstrated right here. So the final imbalance which we'll talk about is leg dominance. And again, as we reviewed from yesterday, it's the imbalance between muscular strength and recruitment on side to side. Now typically, after ACL reconstruction, the dominant leg turns into the unaffected side, whereas the ACL reconstructed limb turns into the non-dominant or the unaffected side. So our mission here should be to try to, again, gain balance. And I think we can appreciate the importance of that based on our return to sport lecture from yesterday. Again, if we see these side-to-side differences, we know that that'll set us up or actually be a predictor for future ACL injury. So again, based on the work by Neitzel, who demonstrated that even with a simple squatting task, we were unable to balance forces between our limbs. And then moving forward to studies by Hewitt et al. And others, in addition to our study, which was recently published this last year, we can appreciate that side-to-side differences are a risk factor for future injury. And as a result, we need to guide our interventions in such a way to ensure that we're trying to encourage our athletes to be balanced side to side, so they don't continue to utilize their uninvolved limb as their preferential limb for the majority of their athletic tasks. So when we think about the female athlete, because again, we know that the female athlete is a high-risk athlete, we can look back to the work of Kevin Wilk, which was published in the Journal of Athletic Training in 1999. And again, we see this list, which he published in 99, is very similar to those means that we can utilize to target these three neuromuscular imbalances. If we control valgus motion, if we train coactivation, if we utilize, we try to improve muscle endurance, muscle strength, and muscle reaction time, if we focus on all of these parameters, I think we'll be more successful in returning our athletes to sport in a safe manner. So before we talk specifically about how we progress our athletes from the day after surgery to a point when they're ready to participate in a return to sports program, let's think briefly about some of the history of rehabilitation, because I think it's important to think previously how we used to treat our athletes and how we've advanced over the years. And if we think back to 25 or 30 years ago, accelerated rehab was considered not placing someone in a cast. Immediate motion was thought to be revolutionary in the early to mid-'80s. And from there, we progressed very quickly to a more accelerated rehabilitation approach, where we went from having someone in a cast for several months to actually getting them back and returning to sports in several months. And during this dramatic shift of time, I think we can appreciate that either end of the spectrum is probably not the most appropriate position for us to train our athletes. And as a result, the pendulum has now swung and probably has rested somewhere in the middle to where we are today. And from that, I think we can appreciate that there's appropriate interventions and appropriate time frames to utilize, that we respect the healing tissue of the ACL graft, but still progress our athletes as quickly as is functionally possible. So when I think about my ACL rehabilitation, I like to break it down into several phases, and the first of those phases being the acute phase. During the acute phase, it typically lasts for the first few weeks after surgery. And during that time, we like to progress our athletes, ensuring they have good range of motion, 0 to 90 degrees. We progress them with the weight bearing as tolerated status. However, we don't progress them off crutches until they demonstrate full knee extension, adequate knee flexion to have a normal gait pattern, no pain, and no signs of swelling. Once those parameters are met, then we progress our athletes off crutches, which typically occurs between 3 and 4 weeks after ACL reconstruction. During this time, we advocate the use of modalities for muscle re-education, such as neuromuscular stim, and we certainly manage pain and effusion with the use of ice and cryotherapy. From an exercise perspective, during this acute phase, we focus on lower extremity stretching to encourage full knee extension. Our first priority in the acute phase is to regain full knee extension as quickly as possible. We want to initiate good quadricep control, because the longer that the quadricep is inactive or is hypertrophying or atrophying, the longer that the ultimate rehab will extend as we continue to work on the end stages of rehabilitation on improving our strength. We want to ensure they have normal patellar mobilization, good gait retraining interventions, and maintain balance and proprioceptive activities. As we move forward into the subacute phase, we have to ensure that they have good range of motion. Our goal is to progress the range of motion over the next several weeks to their full range of motion, being 135 to 145 degrees of flexion. We want to ensure that they're progressing off crutches when they've met those criteria, which I previously mentioned. We continue to use modalities as needed to enhance quadricep recruitment and also control effusion and swelling. And we want to initiate more lower extremity conditioning activities. Our progression of exercises during this point is an ongoing continuation of the acute phase. We want to progress to doing more closed kinetic chain activities to enhance that proprioceptive feedback that our athletes get by doing some activities in a weight-bearing position. We can initiate isotonics in a controlled range. The prior literature has suggested that the ranges for leg press are very safe between 70 and 10 degrees. Leg curls are safe from 0 to 90 degrees, and leg extensions can be safe between 90 and 30 degrees. However, we're very careful that we don't put undue stress on a healing graft. In addition, we continue to progress balance and proprioception. So here we see some exercises which we'll initiate early on in rehabilitation. And this is one exercise, especially on the heels of our conversation yesterday, where we learned that some of the predictors of future ACL injury after ACL reconstruction are in fact hip extensor moment and hip rotation moment. We try to do activities which are going to recruit the hip abductors early on. So something as simple as sidestepping over cones, where we ask them to raise their knee to the height of their hip repeatedly, will give them an opportunity to start to work their hip abductor and hip strength. In addition to this, we'll offer some resistance with bands between their legs to, again, try to challenge their hip strength as time goes on. From this, we can make this task more challenging by giving them a perturbation along the way and asking them to catch a ball or giving them some distraction as they continue to progress through the rehabilitation. Here we see, again, a progression to moving from a stable surface to an unstable surface. So again, having a stepping task. And again, we start in one plane, moving in a sagittal plane, stepping onto a stable surface, and then progressing onto a surface such as this and stepping onto an unstable surface. Asking them to step and hold is training their knee and their lower extremity to work as a stabilizer. From here, we move not only in a sagittal plane, but also into a frontal plane. So again, as we spoke before about the mechanism of ACL injury, we can appreciate that the ACL injuries occur in 3 planes. And as a result, our interventions need to occur in 3 planes as well. So progressing from not only a sagittal, but also a frontal plane maneuver as well. And then ultimately moving to more rotational tasks as we see here. So we see a simple 90-degree step onto a stable surface, and then progressing this to a more unstable surface is a nice way to challenge our athletes. In addition, we talked previously about training co-activation and having them do squatting type tasks. And here we see a progression of that simple squat on an unstable surface, which we saw previously, to squatting in a more 3 planes. So again, having them on an unstable surface and asking them to squat and rotate at the same time. And then ultimately progressing that to a point where they're having some distraction as well. So catching a ball, throwing a ball, having some other challenge as well. From here, we move on to our next phase, which is the 3rd phase. But the criteria needed to meet to progress to this 3rd phase is having good quadricep control, normal range of motion, good patellar mobility, having a stable KT1000, so no changes in graft AP laxity, minimal effusion, and no patellofemoral pain. And this next phase I like to call the neuromuscular development phase, because we've worked through some of those acute and subacute deficits, which we typically see post-operatively. And now we're advancing on to a phase where we can start to work on enhancing our strength. So the goals of this phase are to progress the current program to really maximize our strength and endurance, to focus on the development of good technique, to advance our current balance and proprioception activities, and then at the end of this phase to initiate a light plyometric program focusing specifically on technique. So again, ways that we can advance this is to give perturbation with some of our interventions. So again, not only asking our athletes to stay on an unstable surface, but then perturbating them as well. Here we can see a perturbation in 3 planes as well. So having them stand on an unstable surface and challenging them by having unanticipated perturbations. And again, if we think back to Lloyd's study, which suggested that when unanticipated perturbations occur, we have a decreased stability in the knee. We need to start to train our athletes to have a quicker reaction time, and early on in rehabilitation in this phase, we can start to initiate that type of intervention. The next is the transition to function phase. So once we move beyond that neuromuscular re-education, we want to make sure that we start to give our athletes an opportunity to build upon the strength and endurance that they've built early on in their rehabilitation and utilize those skills in activities which are very relevant for them as they progress onto their ultimate goals. So from this phase, we take some of the technique training we did in plyometrics and we advance it on. So we enhance the plyometric program specific to what the patient's goals are. We initiate a stronger running program. We start to think about doing pivoting and cutting as their criteria are met. And some of the things we can advance to are looking to do our higher level plyometric activities. So progressing from a very easy plyometric activity, such as a double leg broad jump, to ultimately moving to a single limb activity, and then ultimately progressing from a stable surface to hopping onto an unstable surface as well. And again, we need to think not only in the sagittal plane, but we need to think in the frontal and rotational plane as well. So again, advancing our activities beyond a simple sagittal plane hop, and then progressing on to more frontal plane activities as well. And then ultimately, we want to go through what we consider a return to play phase. And this should be very specific to your athlete and the goals which they have, whether it's soccer, basketball, or whatever other activity they'd like to return to. But the goal of this phase is, again, to build upon that transition to function phase and look at initiating and progressing the athlete through a pivoting and cutting progression, utilizing sport-specific training based on what their goals are, and really continuing to enhance the strength development which you've built upon along the way. The ultimate goal should be to return to activity, as we mentioned yesterday, both safely, efficiently, and effectively. And I've thrown in several videos of activities that you can incorporate throughout your rehabilitation intervention, but just to think about how we can advance some of these interventions and make them more challenging for our higher level athletes. Doing things such as lunge walking with utilization of weights, there's a way to maintain lower extremity strength and can be a nice adjunct, a strengthening adjunct that you utilize during your return to sport phase. Certainly, core stability is something that we need to work on throughout the rehabilitation program, and it's something that you can initiate very early on in rehabilitation, even in the acute and subacute phase. However, it's something that should not be ignored as you transition through the later stages of rehab. Here we see a very low-level core stability strengthening maneuver, but one that can be advanced and progressed to much higher level activities. We've already seen this exercise demonstrated to being the single leg deadlift task, and again, it's a very nice activity to recruit hip extensors and gluteal activity. However, if we had a frontal plane view, we could appreciate the position of our knee. And again, if we think back to the mechanistic perspective, we need to ensure that this athlete maintains a good hip over knee over toe posture during this task. And once they're able to successfully demonstrate that on the floor, then we progress them to a more unstable surface. And then, as we mentioned before, progressing our plyometrics to a very low-level, two-legged hop onto a stable surface, and then ultimately progressing to an unstable surface as well. And asking the athlete not only to do quick transitions, which is what we traditionally think about in plyometrics, but before we utilize those quick transitions, we should attempt to utilize hop and hold techniques to try to teach our lower extremity to act as a stabilizer, and then progress forward into our higher level and quicker activities. Doing residual strengthening tasks, such as a single leg squat with assistance, as we see here, again, is a nice way to advance to the progression of our closed kinetic chain lower extremity exercises. And then what about plyometric tasks? Because the majority of activities that many of our athletes want to return to include some type of jumping and cutting task. So here we see a drop jump task with an unanticipated cut. So this is a type of plyometric maneuver we like to utilize to try to encourage our athletes to have some type of unanticipated maneuver. So as our athletes jump off the box, as they're in the air, we point in a direction, and they have to react to that and then cut in that direction. And this we feel is a nice transition to doing some of those on-field tests that two of my previous speakers have spoken of. Fantastic things to do in the field: pivoting, cutting, cone drills. But in the clinic, this might be an activity that you can use as a precursor to some of that activity as well. And then ultimately moving to a rotational hop as well. This 180-degree plyometric is a nice way to get the patient to do a very explosive task, do things in 3 planes, especially a rotatory plane, and you give them an opportunity to look at their knee position as they do it. And you'll notice that some of her landings look very good, hip over knee over toe, while others, she starts to get a little bit of valgus as she lands with rotation. So again, we're trying to encourage the athlete to be explosive, to get up in the air as quickly as possible, to get to their position and land in a safe posture. When they're able to do that successfully, then we're able to progress our patients forward. And then finally, one test that we like to use is a tuck jump assessment. And this is a high-level assessment, and we use a criteria that we have published in JOSPT and other publications to look at deficits with a tuck jump. And here we see, as she's going into some knee valgus, you see she's unable to get the knees to the height of her hips, probably not as explosive as some other athletes. She tends to float a little in positions. So all these are factors that we look at to try to determine how the athlete is progressing. And then ultimately, we want to utilize stringent criteria to make that return to play decision, which is what we spoke of yesterday. So again, our goal is to return to activity safely and efficiently. And just to reiterate our points from yesterday, the better criteria we have that are more representative of future injury, the better we are in developing that, and the better we are in customizing our end-stage rehabilitation, I think we'll have a better outcome for our patients. So to summarize, the rehabilitation should focus on controlling abnormal biomechanics. And as we know from a mechanistic perspective, certain biomechanical and neuromuscular deficiencies will result in increased risk of injury. Our goal as rehabilitation specialists should be not only to rehab just that injured knee, but to rehab that whole athlete and to try to address some of these high-risk patterns which are demonstrated in our athletes. When athletes come into our clinic after ACL reconstruction, they've identified themselves as an individual who's at high risk. And it's important for us to look into the literature, some of the ACL prevention literature, and try to apply some of these principles to the end stages of our rehabilitation, because it's a captive moment that we have with these patients during rehabilitation. We have the opportunity to rehab their knee, which they're there for, but also to rehab the whole athlete to hopefully prevent future injury when this athlete. And moving forward, we want to ensure that our return to sports decision, as we discussed yesterday and today, is very objective and based on objective criteria. So hopefully we can change and improve the outcome for our patients. And again, I'd like to acknowledge my coworkers who are instrumental in our success in our lab, and I'd like to thank you very much for your attention today. Thank you.